Hi, this is Leslie White with Jacksonville State University for NU 527. This is my PowerPoint presentation on osteoporosis in the geriatric population. Osteoporosis is a disease that is characterized by low bone mass and structural deterioration of the bones. It's a silent disease, which means that it often has no symptoms until a fracture occurs, and these fractures can often be deadly. One of the problems that we face as nurses is that because there aren't many symptoms, sometimes it's hard to get our patients to take this disease seriously. Over 40 million adults in the U.S. either have osteoporosis or are at high risk of fractures due to low bone mass. While as a disease it does affect both men and women, women are definitely more affected by it. The percentage of men who are 65 and older with osteoporosis of the femur, neck, or lumbar spine is 5.1%. Meanwhile, the percentage of women 65 and older with the same is 24.5%. While it often gets less attention than other major diseases like heart disease and cancer, osteoporosis can absolutely be deadly to the geriatric population. 1.5 million Americans will suffer a fracture related to bone disease each year. As nurses, we know anecdotally how detrimental a fracture can be to an elderly patient, but the numbers are truly staggering. 1 in 3 women and 1 in 12 men will suffer a hip fracture. One-year mortality rates for hip fractures in those 65 and older are 14 to 58%. Relative mortality risk increases by 4% with each year of age. Besides the risk of dying, fractures are also associated with significant loss of independence and financial burden. 2/3 of hip fracture patients will not regain their level of mobility prior to fracture, and many of these will also become majorly depressed. Prevention, detection, and treatment of osteoporosis should be a mandate of primary care providers and nurses. Primary prevention aims to prevent diseases before they occur. In the case of osteoporosis, educating our patients on proper diet, exercise, and avoidance of tobacco and excessive alcohol consumption are effective ways to prevent the onset of bone disease. For diet, we should be encouraging our patients to make sure that they take in enough calcium. That's 1,000 milligrams per day for men 50 to 70 years old, or 1,200 milligrams per day for women 51 and older and men 71 and older. We also need to be recommending that they take in enough vitamin D, which helps with the absorption of the calcium that they're taking in. That's going to be 800 to 1,000 IUs per day, and they need to be taking supplements if necessary. Adequate exercise is also very important for the prevention of osteoporosis. Weight-bearing and muscle strengthening exercises, as the patient tolerates, can improve agility, strength, and balance and help to maintain or improve bone density. As always, we should be encouraging our patients to avoid tobacco use and also to avoid excessive alcohol intake. Among other things, this may worsen bone density loss. Next, we're going to move on to secondary prevention, which seeks to identify disease processes early through screening and medical testing. Early intervention can help to prevent a disease from progressing. One very simple and cost-effective way to screen for early osteoporosis that we can do as nurses is to measure height annually. What we're looking for here is height loss. So we can use historical height, which is from the peak height at age 20, a loss of 1.5 inches or more, or a prospective height loss from any previously documented measurement of 0.8 inches or more. These will indicate a need for further screening. We can also recommend bone mineral density tests to screen for osteoporosis. Women 65 and older or men 70 and older should have these. Postmenopausal women or men 50 to 69 with high risk factors, or postmenopausal women and men 50 and older who have a history of an adult age fracture. These tests are usually covered by Medicare and other major insurance, and they are low risk for complications. The potential for unintended harm from these tests is very low. There are a few different types of bone mineral density tests. The central DXA of the hip and spine is the gold standard. It takes about 15 minutes, it's non-invasive and painless, and it exposes the patient to very low amounts of radiation. If it's unavailable, then a peripheral screening test can also be done. It's less accurate than the central DXA, but it does provide some info if the DXA is not available. Bone mineral density tests are then reported with a T-score. A T-score of -1.0 or above is considered normal. Between negative 1.0 and negative 2.5 is low bone density or osteopenia. Below negative 2.5 is diagnostic for osteoporosis. Depending on risk factors and bone mineral density testing, vertebral imaging may be indicated. All women 70 and older and all men 80 and older should have it if the T-score is less than or equal to negative 1.0 at the lumbar spine, total hip, or femoral neck. Women 65 to 69 and men 70 to 79 if the T-score is less than or equal to 1.5 at the lumbar spine, total hip, or femoral neck. And postmenopausal women and men 50 and older with specific risk factors should be referred for vertebral imaging. Finally, we have tertiary prevention. Once we have a diagnosis of osteoporosis, tertiary prevention helps our patients to avoid the worst complications of the disease. One of our priorities for tertiary prevention in this group is fall prevention. Most fractures related to osteoporosis are secondary to a fall. Education is so huge here because fall prevention is simple and inexpensive. One thing that we can do is teach our patients how to make their homes safer. We need to encourage them to avoid clutter and items that can be tripped over, like cords and rugs. They need to install grab bars in their tubs and showers. We need to help them make sure that all stairs have railings, preferably on both sides, and make sure their homes are well lit. Some of our patients may need help finding someone to help them install these things in their homes as well. Another simple intervention, encourage our patients to wear their glasses when performing daily activities, not just when they're reading or watching TV. Also, as mentioned before, we want to continue to encourage exercise. This helps improve strength and balance and can help prevent a deadly fall. In our practice as APHNs, we may want to take advantage of the FRAX tool. The FRAX tool is a free screening tool that's available on computer or paper that estimates the 10-year probability of a major osteoporotic fracture. This tool can be used by nurses or advanced practice providers to help quantify patient risk and to formulate care plans. We also want to consider pharmacologic treatment for our osteoporosis patients. While we as nurses can't prescribe medications, we can refer our patients to providers who can. These medications can help treat osteoporosis symptoms. After they start treatment, we want to make sure that our patients understand that they will need continued monitoring. Bone mineral density testing should be completed 1 to 2 years after the initial treatment begins and every 2 years thereafter. In addition to understanding the disease and the roles in prevention that we have, the advanced population health nurse has many other roles to play in the management of osteoporosis in the adult gerontology population. In this role, we are also focusing on population-based interventions. These are effective. The Office of the Surgeon General found that population-based interventions to increase physical activity levels and to reduce tobacco use is correlated with better bone health. It's important for us to realize that policies are effective interventions. Nurses should be active in advocating for policies that improve patient outcomes. Here are some examples of times in the past where policies have been successful in helping our patients. Tobacco policies and laws have successfully decreased the use of tobacco products and encouraged cessation among high-risk geriatric populations. Things like increasing taxes on tobacco products to make them cost more, mandatory education about quitting in the hospital, and limiting places where you can smoke have all led to decreased numbers of smoking among the geriatric population. Another example of success are policies for increasing physical activity. The Task Force on Community Preventative Services has done things like community-wide information campaigns, point-of decision prompts like signs encouraging stair use, improvements to access to safe areas for physical activity, and programs for individual success. Finally, as an APHN, our role is often helping our patients access the care that they need. We provide education and screening for low-income populations, referrals to low-cost clinics, help with medical forms, and insurance applications. We can also refer our patients to social and activity programs to encourage physical activity and better nutrition. Programs like Silver Sneakers, Senior Centers, Meals on Wheels, EBT, and food assistance programs can help get our patients access to the physical activity and nutrition that they need. In conclusion, osteoporosis can be successfully managed by healthcare providers in the geriatric population to minimize the incidence of complications and disability. Here's our references for this presentation. Thanks so much for your time, and have a great day.